Welcome to MLT 101, Infection Control. My name is H1 Barnes. We'll be starting with terminology. Biohazard, short for biological hazard, is any biological material that is harmful or potentially harmful to health. Biosafety is the term used to describe the safe handling of biological substances which pose a risk to your health. A blood-borne pathogen is the term applied to any infectious microorganism in the blood or other body fluid. CDC stands for Center for Disease Control, which is the division of U.S. Public Health Service that is charged with investigating and controlling disease that has epidemic potential. DOT stands for Department of Transportation. NIOSH, the National Institute of Occupational Safety and Health. It's our federal agency responsible for conducting research and making recommendations for the prevention of work-related injury and illness. And OSHA, the Occupational Safety and Health Administration. They are the U.S. government agency which mandates and enforces safe working conditions for employees. The chain of infection is a condition that results when a microorganism, often called a microbe or pathogen, is able to invade the body, multiply, and cause injury or disease. Our microbes include bacteria, fungi, protozoa, and viruses. A pathogenic microbe, which means it can cause or produce disease, is called a pathogen. You will typically, and by typically I mean always, have non-pathogenic microbes on your skin and in your body. You are covered in bacteria. They're called normal human flora, is how we call them in the laboratory. And you have bacteria in your gastrointestinal tract, in your GI tract, that we call normal gut flora. That is expected to be there. They perform beneficial biological functions, and if they're not there, it can cause other pathogenic organisms to move in and take the spot that would have been taken by a non-pathogenic normal organism. When that happens, you can get sick, very sick. However, just because something is normal to have does not necessarily mean that it doesn't have the potential to get you sick. Normal flora can become pathogenic if it enters an area of your body where it's not supposed to exist. You have bacteria in your gut. That is normal. But if those bacteria go from assisting the digestion in your gut to hanging out in your eye, now you've got a problem. In your intestines, that's normal. But if they're in your eye, now you're going to get an eye infection. So bacteria may be pathogenic depending on where you're exposed to them, not just what type of bacteria it is. That is something to consider. There are different types of infections as well. A common term that is of concern in the healthcare industry is the term nosocomial infection. It's what we call a patient infection that is acquired in a hospital. There is a newer, broader term called a healthcare-associated infection that applies to any infection acquired during healthcare delivery in any healthcare setting, even including home care. If someone's receiving home care and they get sick at home, you could technically call that a healthcare-associated infection. They can result from contact with various sources, including infected staff members, other patients, visitors to the hospital, or contaminated food, drinks, or objects, or even medical equipment. In 2011, the CDC found that on any given day, about 1 in 25 patients in a U.S. hospital has at least one healthcare-associated infection, and up to 1 in 9 of those people end up dying from it. The most common type of healthcare-acquired infection is a urinary tract infection, or a UTI for short. They make up just under 1/3 of all healthcare-acquired infections. The reason that these infections have such a high fatality rate is because the hospital is a concentration, an aggregation of sickness and illness. People bring their diseases to the hospital to get cured. The most resilient ones, the strongest pathogens, are often the ones that are able to be coughed out from someone or get touched onto a doorknob, and they can survive over time and then grow in that environment. So you have to be very careful with your hygiene processes to prevent those from spreading. And that brings us to the chain of infection. The transmission of an infection requires the presence of a number of components that we refer to as the chain of infection. There are 6 links in this chain, and if you break any one of the links, you can remove it. If you remove that link from the chain, the infection doesn't happen. It doesn't spread from one person to another. The links in this chain are the infectious agent, that is the pathogenic organism itself, the reservoir, which is the source of the infectious agent, such as food, soil, other people, animals. It can be contaminated equipment or medications that there was a bad batch at the factory and they got contaminated. That can be a reservoir for an infection. Then you have the exit pathway, which is how the infectious agent, that pathogenic organism, leaves the reservoir, makes it out into the environment. It can be coming out of the eyes or the nose or the mouth of a person or an animal. It can come out from blood in a wound, the excretion of feces or urine. The means of transmission is the method that your infectious agent uses to travel. So it's exited the reservoir and now it travels from the reservoir to a potential target or host. The entry pathway is how that infectious agent enters the susceptible host, that pathogen's target. An entry pathway can include an orifice in the body, such as your eyes, your nose, or your mouth. Those are very common ones. If you have a break in the opening of your skin, or it can also be caused by an invasive procedure. If someone is receiving a catheter or you're drawing their blood and you don't clean their arm first, or a poorly performed finger stick or heel puncture or surgery, all of those create a break in the skin or an entryway into the body that a pathogen can use. A pathogen can have an entryway into a healthcare staff member through exposure of a splash or a spill of someone's body fluid or a sample, or that entry pathway can be created by someone accidentally poking themselves with a used needle. We call that a needle stick injury, and it is of great concern in the laboratory environment because when there's not dedicated phlebotomy staff around, a lot of times they'll come to us to draw the patient's blood. So we handle needles that have other people's blood on them. And last, we come to a susceptible host. A susceptible host is anybody that has a decreased ability to resist that infection and can be made ill from that pathogen. Some factors that can affect someone's susceptibility include their age. Typically, it's the youngest and the oldest. You have newborn babies and the elderly. They're the people that are most susceptible to becoming ill. You can be exposed to a pathogen and not even know it because your immune system just beats it right away. It's in your body for a day or two, your immune system kicks its butt, and you're healthy again. But during that time, you spread it, and now a little baby caught it, or an old person caught it, and they can't beat that infection with the same vigor that you did. So they do get ill from it. Someone's health can also affect them. If you're around people that are of generally poor health, they are more susceptible to getting sick with something new. Immunocompromised status or taking immunosuppressive drugs can also greatly affect this. Things like surgery, anesthesia, inserting a catheter, all of those can leave someone more susceptible to infection. One that people don't usually consider when they think of this kind of stuff is taking antibiotics. If you take antibiotics and it wipes out a large chunk of your normal bacterial flora that's on your skin or in your gut, it leaves room for pathogenic bacteria to come in and take the place of the good bacteria that used to be there. So even taking antibiotics can actually open someone up to being a susceptible host for a new infection. To be able to spread, this infection has to be transmitted somehow. One of the primary methods of concern for transmission of an infection is airborne transmission. It involves the dispersal of an infectious agent in the air that is usually less than 5 micrometers in diameter. The particle that it's spread with is less than 5 micrometers. Whether it's a tiny little bit of mucus or saliva left over from someone's sneeze or a cough, or if they're talking, it's small enough of a particle that it can float suspended in the air, or it can attach to a piece of dust and just float there. There are different viruses and airborne infectious agents that can remain in the air for hours, not just a few minutes, hours. If someone coughs in an elevator and they have one of these airborne illnesses, and you ride that elevator 2 hours later, you can inhale the floating viruses in the air and catch that illness. Airborne transmission is of great concern for that reason. Next, we have droplet transmission. Droplet transmission is similar to, but different from airborne transmission. Because droplet transmission, we're talking about particles that are bigger than 5 micrometers in diameter. They're too big to just float in the air. They come out of someone's mouth or their nose, and instead of floating in the air, instead of being directly inhaled, just floating there, they land on the surrounding surfaces. Or if you're talking to someone close by face to face, it could go from their mouth straight into yours and directly infect you just like that. The key difference here is airborne is smaller than 5 micrometers and it floats in the air. Droplet is bigger than 5 micrometers and it falls out of the air and lands on different surfaces. It's still coming out of somebody's mouth. It's still coming out of somebody's nose. It's the size of the particle that makes the difference here. Next, we have contact transmission. It's often considered the most common means of transmitting an infection. We've got 2 main types of contact. There's direct contact. Think person to person. You touch someone, you're sick, you give them the disease, now they are sick. It can be spread from something as benign as just a touch from one hand to another hand or a shoulder, or people kissing. And then you have indirect contact. Indirect contact occurs when the infectious person or other reservoir makes physical contact with an object and leaves some of that pathogen behind. A sick person goes and they touch the public phone. They leave that pathogen on the phone. A susceptible host comes up. They make contact with that phone. They've picked up that pathogen. It's on their hand now. If they put the phone on their face, it's on their face now. If they scratch their eye, or they pick at their teeth, or even apply some cosmetics, it can cause that picked up pathogen to enter into their body. And we call that indirect contact transmission. This can happen without somebody even knowing that they're sick at all. There are many illnesses that people can acquire throughout their lives where you get sick with it once. A lot of times you'll get an illness, you're sick with it when you're a child, your body fights it off and you're not showing symptoms ever again. But that virus has managed to integrate itself into the DNA of some of your cells. And now it is a permanent part of your body, of the genetic code in some of your cells. It will continue to periodically reproduce itself in your body. And at certain times in your life, usually when someone undergoes a lot of stress or a tough period in their life, this virus can reemerge when their immune system is weakened and start to shed again. This can happen especially with things like Epstein-Barr virus, which is known for causing infectious mononucleosis. A lot of times it's referred to as the kissing disease because it's so easily transmitted. If you live in the United States, there's about a greater than 90% chance that at some point in your life, by the time you're 18, you will have been exposed to this virus and are then able to shed and transmit it to other people, and you won't even know. Next, we have vector transmission, which is the transfer of an infectious agent that's carried by an insect or an animal. Examples would be West Nile virus from mosquitoes, or if you live in the Pacific Northwest or West Coast, bubonic plague from the fleas on rodents. A lot of people think of plague as something that we don't have to deal with. There's about a half dozen naturally acquired cases of plague in the United States every year. A lot of times it's people who live on the edge of town, near the woods. The animals will come into their yard. They'll have fleas. Those fleas carry bubonic plague, and the fleas might get on their pet, and from the pet, it gets in the person's home. This is something that, while rare, does happen. We also have vehicle transmission, which is the transmission of an infectious agent through either contaminated food or water or medication. Examples would include a salmonella infection from handling contaminated chicken, or a Shigella infection after someone drinks contaminated water. Every hospital is required to have an infection control program. The Joint Commission, often referred to as TJC or JCO, requires this. It's responsible for protecting your patients, for protecting your employees, anybody who visits the hospital, and anyone who does business within that healthcare facility. And the goal is to protect people from infection, to break the chain of infection so that illness does not spread. Your standard infection control program is going to also monitor and collect data on all infections that occur within the institution. You don't only track what people bring in from the community, you track what happens within the walls of your own facility as well. Something to keep in mind is the pathogens that we are tracking, these infectious organisms, are not visible to the eye without a microscope. Some of them are invisible to the eye even with a microscope. You're not going to see them with anything less than a scanning electron microscope. And most of us do not have those. It is the responsibility of the entire team to take measures to help prevent the spread of these infectious microbes. It is everyone's responsibility. It's not just the nurses, it's not just the doctors, it's not just the pharmacist, or the x-ray tech, or the physical therapist, not just the lab. It's everyone's responsibility. A good infection control practice is going to help prevent not just the spread of infection in your healthcare facility, but it'll also prevent the spread of infection going out into the community. You do not want the pathogens that are brought by your patients into the hospital to spread back out into the community, because that's how you get epidemics. You do not want that to happen. Your infection control committee is critical in preventing that. Infection control programs are going to prevent infection partially through screening new employees and implementing immunization programs. You're going to screen people for infectious disease, usually prior to employment or immediately upon employment. It's also going to be done periodically throughout the time somebody works in that healthcare facility. Your screening tests are typically going to include a test for tuberculosis and frequently also include tests for diseases that can be spread through the fecal-oral route, like diarrheal diseases, or diseases that can be spread through physical contact, such as skin diseases. Employees that have certain conditions, such as transmissible infections, may be subject to different work restrictions. You don't want to have somebody who can easily spread a pathogenic organism working on the front lines of patient care, hands-on with your patients. It doesn't necessarily mean they can't work with you, they can't be part of the team, but you don't want them in that environment where they could potentially cause someone to get sick from what they carry. So you would instead have them away from the patient care aspect of the facility in a more administrative or managerial role, something along those lines. Immunizations that are required are usually going to include hepatitis B virus, that's our HBV, your MMR, your measles, mumps, and rubella, diphtheria and tetanus vaccine, and typically you have to provide proof of immunity for this. If you cannot provide proof of immunity, you'll have to go receive new vaccinations. Hepatitis B virus is of great concern, especially in the lab community, It's a virus that attacks your liver and can be life-threatening. It has the ability to transfer itself from being an acute infection and do what we call going chronic, where that infection now becomes a lifelong infection. You will not be able to cure it. It is what will eventually kill you, and it may take a decade, but it's destroying your liver from the inside, and you now know what's going to kill you. It's going to turn your skin yellow with jaundice. It's going to prevent your body from properly producing protein, so you're going to feel tired and weak and just overall terrible. You do not want to get hepatitis B. It is the most frequently occurring lab-associated infection and the major occupational hazard in the healthcare industry. Our best defense against hepatitis B is vaccination. The vaccination schedule for this is you get an initial dose, followed by a second dose a month after that, and a third dose 6 months after the first dose. That is your hepatitis B vaccination schedule. If you don't follow that schedule, there is a real risk of the vaccination not working. And even if the schedule is followed, vaccines are not perfect. They do not always work. And even if you've been vaccinated in the past, over time, you may lose immunity to what you've been vaccinated to. I know this firsthand because when I initially got into the laboratory field, I was immune to hepatitis B. I did not need to go get vaccinated for it. I had an immunity screen done. My test results said I was good to go. About 4 years or so later, when I decided I wanted to further my education, finish out a bachelor's degree in this field, I had to go back and provide proof that I was immune to hepatitis B. And when I went to go get that screening test performed, it came back that my immunity had waned. I was no longer immune to hepatitis B, and I needed to redo the entire series. This is something that can happen. So you have to periodically make sure that you are protected from these illnesses. OSHA regulations require your employer to offer you the hepatitis B vaccine for free within 10 days of being assigned to duties where you have the potential to be exposed to a bloodborne pathogen. So if you want to think of that as 2 work weeks, if you have 5 8-hour days one week, 5 8-hour days the next, they've got about 2 weeks to offer you that vaccine. Employees who refuse Hep B vaccines, and that is a bad idea, unless there is a very, very specific reason why it's not safe for you to get that vaccine, it is a bad idea to not be Hep B vaccinated and work in the medical community at the same time. I highly recommend that you get your hepatitis B vaccine if you are ever going to be in a position where you're exposed to bloodborne pathogens. But employees who choose to refuse Hep B vaccinations must sign a declination statement, which will be kept on file by their employer. Because if that person later catches hepatitis B, which they are likely to do, because the infection rate for hepatitis B, if someone is exposed to it through the bloodborne route, can be as high as 50%. For reference, less than 1% of people who get exposed to HIV through the bloodborne route, such as a needle stick exposure, and follow up for treatment, actually contract HIV. About half the people that are exposed to hepatitis B catch hepatitis B. If you work in this field long enough, you will eventually be exposed to it. And if you are exposed to it and not protected from it, there is a high chance of you contracting this virus. So they have to keep your statement of refusal on file if you refuse that vaccine. And if you refuse and you catch that virus, your employer is not liable for you catching that because you chose to expose yourself to that. Most employers are going to provide all vaccinations that you need for employment free of charge. And let me tell you now, if they don't, you might want to reconsider working at that facility because they do not have your best interest in mind. An infection control program also provides for the evaluation and treatment of employees who get exposed to an infection on the job. That is another major function of your infection control program. We call it surveillance or monitoring. It involves watching patients and employees that are at risk of acquiring infection, as well as collecting, evaluating, and distributing data on infections that are contracted by your patients or employees. The most important thing that you can do, aside from getting vaccinated, when it comes to breaking the chain of infection, is good hand hygiene. It is the number one infection control practice. The number one. Good infection control prevents the spread of infection in your healthcare setting, and it prevents you from getting the community sick. The most important part of that is hand hygiene. There are different methods of hand hygiene, such as hand washing or hand antisepsis, depending on what level of cleanliness you need to achieve. If your hands are just routinely dirty, regular hand washing with soap and water, which physically removes any bacteria, is typically fine. If you're going to go into a clean procedure, that's when you need hand antisepsis. You're no longer just using regular soap and water. Now you are using antimicrobial soap, which has chemicals in it that will chemically attack and kill microorganisms. Regular soap that you just buy at the store does not do that. It just physically helps clean things off. It does not chemically kill them. Hand hygiene will also frequently include the use of alcohol-based antiseptic, known as hand sanitizer. This is a great alternative to hand washing when you do not see any visible soiling of your hands. That means your hands aren't dirty when you look at them. If you look at your hands, there's no blood, there's no dirt, no grease or grime or anything on your hands. Sanitizer is great. But sanitizer isn't meant to remove things from your hands the way hand washing does, so it doesn't make them cleaner. It just kills what's on them. Something to be aware of is that as you go from task to task and you sanitize your hands in between seeing your patients, is that sanitizer will build up a thin residue on your hands. And when you go to put your gloves on, if you've sanitized your hands 4 or 5 times without having actually washed them in between, that residue can build up to the point that it will stick to the material of the gloves, and it can make it hard to put your gloves on. At that point, go actually wash your hands with some soap and water. It'll get that residue off your hands, and then you can put your gloves back on like normal. That's just something to be aware of. The next part of breaking the chain of infection is our personal protective equipment. We call it PPE. It's the protective clothing or other items that we wear to protect our mucous membranes, airways, skin, and clothing from contact with infectious substances. When used properly, it's going to provide a physical barrier against infection, and it will protect you while you wear it. The type of PPE that you need to wear is going to depend on what you're actually doing and what precautions are required for what you're working with. OSHA requires that the institution provide employees with all necessary PPE. What that means is, by law, your employer has to provide you with the personal protective equipment that you need to do your job. You don't have to buy your own gloves. The hospital has to provide you with gloves. You don't have to buy your own lab coat. The hospital has to provide you with a lab coat. Now, they do not have to provide you with a pretty lab coat, but they do have to provide you with a lab coat. Gloves. We use clean, non-sterile gloves. I specify non-sterile and clean. Those are specific terms because when we're doing phlebotomy is not a sterile procedure. It is a clean procedure. We perform antisepsis to chemically kill pathogens that are on the skin, but we are not sterilizing it. There is a difference. So you use clean, non-sterile gloves when you're collecting or handling blood or other body fluids, or handling any potentially contaminated items, or dealing with non-intact skin or mucous membranes. Anytime you might deal with a moist part of someone's body, you also need gloves. When you wear your gloves, you're going to pull your gloves over the sleeve of your lab coat. You don't pull the coat over the gloves, you pull the gloves over the coat. That helps keep that material off of your coat. There's 3 main reasons to wear gloves. You want to prevent the contamination of your hands. You want to reduce the chance of transmitting a pathogen from your hands to your patient. and you want to produce or reduce the possibility of transmitting a pathogen from one patient to another patient. So the gloves are not just for you. 1/3 of the reason that you're wearing gloves is to protect yourself. Wearing gloves during phlebotomy while you're drawing blood is mandated by OSHA. You have to wear gloves. It is not optional. It is not a choice. Glove use also does not replace the need for hand hygiene. You still have to use sanitizer or wash your hands between every patient encounter. Usually that should be done immediately after you remove your gloves, before you go back to another patient or before you go back to the lab or any other workplace duties you have to perform. There is a specific procedure to remove your gloves. When you're wearing 2 gloves, what you're going to do is take one hand and gather your fingers and pinch the glove material in the palm of the other hand. When you've pinched that material, you're holding onto it tight, you peel the glove off, you pull it back off that hand so that you now have one ungloved hand. With the gloved hand that is now holding that loose glove, ball up that disposed glove in your hand, the gloved hand. With your ungloved hand, you're going to take 2 fingers and you're going to slide them up underneath the cuff of the glove on your gloved hand. Continue sliding them up along the side of your hand until you can peel that entire glove off your hand. As you do this, it's going to flip that glove inside out, and within that inside out glove is going to be the other balled up glove. Now all of the dirty, contaminated material is contained within that flipped inside out glove, and you can safely dispose of those gloves. Next, we have our gown or lab coat. It is a clean, non-sterile, fluid-resistant coat. It's worn by healthcare personnel to protect the skin. There's a difference between the lab coats that we typically wear in the lab and the lab coats that you'll usually see a physician wear or a family doctor wear. The ones that your family doctor wears are more along the lines of a tailored, bright white suit piece than they are an actual piece of protective equipment. They're designed to represent an iconic job role and create an appearance. Ours are strictly functional and oftentimes are meant to be either just bulk laundered with the hospital laundry using high-grade disinfectants, or to be completely disposable and thrown away at the end of the day, or if you spill anything on yourself. Because there's a much greater chance of us having to use the protective aspects of these coats. Our coats are focused purely on that protective aspect and the utility function of that. Then we have our masks, our face shields, and our goggles. Your mask is worn to protect against droplets that can be generated by coughing or sneezing, and they should be single use. If you're working in the lab, you are not wearing one of those reusable masks that are made out of fabric that everybody bought because of COVID back in 2020, 2021 timeframe. Those don't cut it. You need to have a disposable mask that you throw away at the end of the day. You do not want to take things home from your lab to your house and get yourself or your family sick. You're also not going to hang that mask around your neck, because if you do, it can become a reservoir for bacteria and viruses. Your face shield, mask, or goggles are worn to protect your eyes, nose, and mouth from a splash or spray of body fluids. And if an activity has the chance of splashing or spraying to where it requires that you need goggles, it also will require that you need a mask. If you are wearing goggles, you are also wearing a mask. Those are for the times when a mask doesn't provide enough protection. We have a higher grade than just a regular mask. It's called an N95 respirator. This is what you're going to wear if you're dealing with airborne transmission protocols and you're worried about something like tuberculosis. These are not something that you just casually buy and casually get. To properly utilize an N95, you have to know the exact size that fits your face. To do that, you get fit tested and trained on how to wear them properly. If the place you're working at is nice, when they fit test your N95, they're going to put the mask on your face and spray some scented spray nearby. If you smell oranges or flowers or whatever they happen to be using, the mask is the wrong size, you'll try another mask, wait a few minutes for the scent to go away, and try again. If it's not as nice of a place, they will take a chemical that is a mucous membrane irritant, similar to tear gas or riot gas, and puff it right in your face so that you can learn what it feels like, so you know what you're testing for. Then they'll have you put the mask on and waft an enormous amount of it onto the mask. You will immediately know if that mask is working or not. There is a specific order for doing what we call donning and doffing our PPE. Donning is the term we use for the act of putting your protective equipment on. Doffing is the term we use for the act of taking it off. When you don a set of PPE, you're going to put on the lab coat first. Then you put on your mask or respirator and face shield. And then you're going to put your gloves on last and pull them over the sleeves of the coat. When you are doffing or removing your PPE, you're going to remove the gloves first, using the process I already told you about. And you do not want to touch a contaminated surface with your ungloved hands. After you remove your gloves, you're going to remove the goggles or face shield by only touching the headband or the earpiece. Next is your lab coat, which will be removed by pulling it from the shoulders towards the hands so that it turns inside out. Now that doesn't always work. Some of these gowns you almost step into. They're like a coat that you put on backwards. The lab coats are typically put on like a normal coat and are removed like a normal coat. But the gowns that are put on by walking into, you put them on your front instead of putting them on your back and buttoning them up. You put them on your front and you tie them up around your back. Those ones, you'll undo the lace and you'll pull it off from the shoulders and turn your hands so that it flips it inside out the same way you would want to flip your gloves inside out. Then you hold it away from your body and roll it into a bundle before putting it in the discard pile. Whether it's a disposable and you put it in the trash or biohazard, or if it is a reusable and you put it in the laundry bin. The last thing you're going to remove is the mask, and you're going to take it off only touching the strings of the mask. Then you'll immediately perform hand hygiene, and depending on the state of your hands, either sanitize them with sanitizer or wash them with soap and water. The reason we have a process that's this specific is there are many times where we're going to deal with people that are sick with something much greater than a common cold. This will seem like it's overkill if somebody comes in and they've got a cold. But if somebody comes in and they've got 105-degree fever and you don't want to catch what they have because there's blood running out of their nose, you need to know how to properly take your gear off and protect yourself. Moving on, we have what's called infection control precautions. Precautions used to be based on either the type of disease or its mode of transition, and often resulted in over-isolation and increased costs. There is a trend in business and in healthcare safety for people to continually chase the concept of perfect safety, where no one ever gets sick and no one ever calls in sick and loses working hours and never has any legal liability. And what would happen is people would continually chase that idea, and in doing so, add on extra layers of precautions and extra layers of precautions, to the point where it would interfere with the basic ability of someone to perform their job. It would cause things like burnout, an increased chance of forgetting some of the steps, making a mistake, and exposing themselves to the disease that they were trying to avoid in the first place, because overly complicating something can be just as bad as not having enough protections in the first place. To counteract that effect, the CDC instituted an infection control strategy called universal precautions, because they were receiving reports that even though all of these things were being done, healthcare workers were still being exposed to and infected with HIV and other bodily pathogens. through contaminated blood and other instances of exposure. Under universal precautions, the blood and body fluids of all individuals are considered potentially infectious. That way, we're not overprotecting against some people and underprotecting against other people's infections. We just treat everybody all the time as if they are potentially infectious when we're working in a healthcare environment. You don't do too much, you don't do too little. You have one set standard. It's easy to remember, it's easy to follow, and you get in the habit of always doing the same thing so that it becomes habit, so that people do it without having to consciously focus and think on it. You want it integrated into the natural flow of what you do while you're at work. Shortly after the introduction of universal precautions, another system called body substance isolation gained acceptance. The intent of BSI, body substance isolation, is to isolate workers from pathogens. This is also followed for every patient, but is another level above universal precautions. So universal precautions is the baseline. It's what you always do all the time. BSI, body substance isolation, requires that gloves be worn when you're in contact with any moist body substance. Standard precautions are also to be used in the care of all patients. Universal precautions are our number one strategy for preventing healthcare-associated infections. This blanket approach is necessary also because a large number of people that have an infectious disease are asymptomatic. They don't know they're sick, you don't know they're sick, and they're still spreading the disease anyways. So if you just treat everybody the same with universal precautions as a baseline, you eliminate the spread of those undetected pathogens, or if not eliminate, at least reduce. Standard precautions combine the major features of universal precautions and body substance isolation to minimize the risk of infection transmission from both recognized and unrecognized sources. So universal precaution is the concept that we treat everyone like they're infectious. Body substance isolation says we don't want to touch bodily fluids with bare hands. Standard precautions combines those ideas together under one term of standard precautions. Transmission-based precautions are used for patients that are known or suspected to be infected or colonized. Colonized is a different term. That means someone carries that pathogen, but it may not necessarily be making them sick. So these infection control procedures are used for patients that are suspected to be infected or colonized with highly transmissible significant pathogens that require special precautions in addition to our required standard precautions. Standard precautions are not enough if your patient's got Ebola. It's common sense. So we have to have levels above and beyond just the baseline. There's three types of transmission-based precautions. There's airborne precautions, droplet precautions, and contact precautions. There are many routes through which our healthcare workers can be exposed to biohazards. We have the parenteral route, which is an exposure from a route other than the digestive tract. Think a needle stick hazard. Ingestion of biohazards can take place if healthcare workers neglect to sanitize their hands before someone eats, before you put gum in your mouth or have a piece of candy, if someone smokes or drinks anything, they can infect themselves. Other activities that can lead to biohazards include covering your mouth with your hands instead of a tissue when you cough or sneeze. Don't sneeze into your hands. Don't cough into your hands. That is disgusting. Cough into your elbow instead. And angle it so that any stray spray, it goes down towards the floor, not up towards other people. Don't chew on your pens or pencils. Don't lick your fingers when you're turning the pages in a book. Airborne biohazards can be inhaled when a splash or an aerosol or a fume is generated. Aerosols and splashers are commonly generated when a specimen is centrifuged, when tube stoppers are removed, and these can be invisible aerosols. You cannot see them with your eye, but that does not mean they are not there. Or when a specimen aliquot is being prepared. A non-intact skin biohazard is where microbes enter your body through visible or an invisible break in your skin, such as an abrasion, a burn, a cut, a scratch, or a sore, or even just chapped skin. We have percutaneous hazards, which is through the skin. Exposure to a biohazardous microorganism in blood or body fluid from an accidental needle stick, or if you cut yourself on broken glass or a specimen tube. Next, there's permucosal biohazards, which is a hazard that enters through a mucous membrane. Exposure occurs when infectious microorganisms and other biohazards enter the body conjunctiva of the eyes in droplets or other mucous membranes through sneezing or coughing, a splash or an aerosol, if you rub or touch your eyes while you're at work, or your nose or your mouth. The term bloodborne pathogen, also known as BBP, is applied to any infectious microorganism that's present in blood or another body fluid or tissue. The BBP standard is mandated by federal law through OSHA and is meant to reduce the chance of occupational exposure to a bloodborne pathogen. Such pathogens, which can be present in body fluids, even if there's no symptoms of disease, are one of the most significant biohazards that we face in the healthcare environment. Although hepatitis B, hepatitis C, and HIV get the most attention, they're not the only pathogens that we worry about. There's also cytomegalovirus, CMV, Treponema pallidum, the organism that causes syphilis, malaria, Creutzfeldt-Jacobs disease, West Nile virus, just to name a few.